this call to order. Thank you. Would somebody be willing to read a motion to approve a meeting by electronic means?
I move that the items on the meeting agenda constitute essential business of this board. Meeting electronically is necessary to protect the health, safety, and welfare of Tennesseans considering the COVID-19 outbreak, and any conflicting with the governor's executive order permitting electronic meetings.
Second. All right, second on Mr. Frederick, is that right? All right, all in favor, can you all raise your hand?
Aye.
I can see everyone, David, everyone. Okay. All right, so actually I can't see everyone, so I'll just do a roll call. Dr. Smith? Here. Ms. Etherington?
Here.
Mr. Frederick?
Here.
Ms. Franklin?
Here.
And Dr. Campbell?
Yes.
All right, great, thank you. There you go. Sorry, it was just the visual was off for a minute. Okay, thank you. There is the minutes from the August meeting were circulated. Any comments or a motion to approve would be taken. I'm happy to entertain either.
I do have a comment
Yes,
regarding the discussion around the vaccine trial. In the minutes, it's noted approved that of those that approve of this or spoke in favor of the vaccine trial contract. But I think I'm asking that you just have a balanced sentence saying that there is robust discussion on both sides, pro and con.
I agree with that because I think even some of us who voted to move forward did agree with some of the concerns that were expressed.
Right. Just a more balanced expression representing the conversation needs to be.
All right. Martha, are you able to do that? I assume you're in the room somewhere.
She's coming into the room.
She's coming in now.
All right.
Yeah, there's something that you need to hear.
So we're talking about the minutes, specifically regarding the conversation that we had around the contract with Clinical Research Associates. Just there was noted that Dr. Hildreth spoke in favor of the contract, but we had a very robust conversation outlining the pros and cons on both sides, and I'm just asking that that be reflected in the record because we spent a great deal of time and it was a very detailed conversation on both sides.
You got that, Martha?
You have lengthy discussion. I think if you would just add discussing the pros and cons of both sides would be helpful.
Yeah.
You want me to encapsulate the pros and cons?
You don't have to delineate them, but just delineate that we did discuss pros and cons from both directions.
Yeah. And that was a very robust.
Because I made the motion to approve it, yet I do understand the reservations and concerns.
Right.
Okay. Martha, you got that reflected correctly?
I do.
All right. Any other discussion regarding the minutes from the August meeting?
What was that additional that you were saying just now?
I'll fill you in a minute.
Okay. With those amendments, is there a motion for approve with the amendments noted by Ms. Franklin?
Motion to approve with the amendments from Ms. Franklin.
Right. Dr. Smith and Dr. Campbell, all in favor, you can show your arm. Any opposed? Today, are you voting yes, no? I don't see your hand. Okay. Any opposed? All right.
I think your camera is frozen. Your video is frozen.
Mine?
Frozen or behind, one or the other.
It might be behind.
Yeah.
All right. Why don't I just, anyone opposed to this? I'm assuming.
No. Everyone in here raise their hands.
Okay, great.
In favor.
Motion carries. Hey, Dr. Caldwell, are you on?
Yeah, yes, sir. Yes, sir. I am.
I just want. I just didn't.
Oh,
there you are.
You see me? I was just having some coffee, and I was trying to be polite.
Yeah, okay. Just want to make sure you were there. I didn't dare to. Welcome to the meeting. Thank you. All right. There you go. That goes there.
No,
now,
I'd just like to say I'm also joined But Dr. Wright is here also to join me, if you see him behind me. So when he needs to speak, he'll be here as well. Okay, thank you.
Dr. Caldwell. Deliberation of end of date of declaration of public health emergency. As we've discussed every month, the declaration of public health emergency that this board placed on in mid-March is the foundation in which all subsequent actions have been based on. We have been reviewing this monthly to obviously to ensure that this declaration is still needed, as well as just to ensure that we're doing our diligence. I believe this declaration has led to a lot of good things that helped us get through this pandemic, from mask mandate to safer at home to a roadmap reopen, and many of the orders we've put in subsequently. We have been reviewing this monthly, but may I propose that we, if somebody would be willing to motion to make this, instead of ending, so right now this ends at the end of September, I would say can we vote to end it at the end of November for now? So it gives us a 2-month buffer instead of a 1-month buffer, just to allow us to, I think it makes things a little, this thing will probably not end before November. We're always able to rescind it if so deemed, but it just kind of gives our department a little bit of clearance of this public health emergency will be in place for at least another 2 months, allowing some of the subsequent orders to have that thing. So I welcome any discussion and or motions around that.
And you feel that the 60-day move is sufficient, or do you think that even moving it out to December might be more appropriate? Because it's most likely to be with us for a while, and we should say we can rescind it, but I just for conversation.
Yeah, I think 60 or 90 days personally for me. I think some of our individuals in the department who really have to live by this daily, from Mr. Smith to Mr. Sharp, Dr. Caldwell, and others, think it would be having more than 30 days will allow us some maneuverability around some, as orders are in and looking at approving plans subsequently. So I'm open to either personally, but I would defer to the board to discuss.
I'm open to the end of December.
That feels right to me for the moment.
Yeah.
Okay, so let me just pose one question about that. By doing that, which I think makes a lot of sense, the only concern I would have is that going to be met with despair and woe by people who are hoping that, the holidays are going to be okay. And one reason that the November date, that takes us through Thanksgiving, but I just feel like we may have to extend it, and likely we will. So it makes perfect sense what you're saying. I do think that there is sort of a real letdown for a number of people who
we do have the roadmap to reopening that if we meet those standards, they would open. So that's within the plan. I do hear what you're saying. As long as that pointed out that we're doing it in the to be more effective and efficient, but we can always rescind it. Yeah,
and I think that's the key point is, and let's say the meeting next month, we want to reevaluate this. Any of you can reach out to Mr. Smith or somebody and say, I want to put this on the agenda to discuss again. I think that there's nothing holding us back from doing that. For efficiency, I think the end of the calendar year makes sense, but I just was proposing in a more conservative or whatever. Yeah, I'm open to either. So I think that's fine. If that would be the motion, I would welcome that. I'll leave it. That would
be my motion, that we extend it to December 31st, and we will revisit it as needed and can rescind if needed.
I can live with that.
So I can live with that. A second, Carol?
Yeah, well, and Dr. Smith.
Dr. Smith have an official second.
Officially. Second.
Okay, Dr. Smith. All in favor, raise your hand. Tanae, is that up or down?
Ours is up.
Mine's up too. Here we go. Tanae, my hand is up too. I agree with this vote. All opposed? All right, motion carries. Thank you. All right, school health update, Ms. Nistler. Floor is yours.
All right, everybody can hear me?
Yes.
All right, and okay, do you have to, no, I'm a panelist, so I should be able to do this. I can't share my screen. Hang on.
Stephanie, you can move the ball.
Yeah. I did miss the name though, if we need it.
Missler, Lisa, Missler.
Oh. Yep.
There she is.
All right, there we go. Okay, well, thanks for having me here today. I really appreciate it. I could talk about school health all day long, so I'm going to try to keep it as brief as I can. I'm Lisa Nissler, and I'm the program manager for the school health program. And I'm going to give just a little bit of history because I know that a lot of you have seen me talk before and have seen what I've presented, but some of you are new, and so I just want to make sure that everybody is going to be able to start from a good baseline. So our contract with MNPS began in 1993, and that was just this small group of nurses who would run a route through Nashville to the schools to provide skilled nursing services for the students. Skilled nursing services being the things like catheterizations, G-tube feedings was mostly what it was back then. Since then, we folded in diabetes care, and we do trach care. I mean, we just do all of it. So that was back then. Then between 93 and 2016, there wasn't a lot of exciting things. The program slowly grew, and then there were times when it went backwards a little bit, and then it would go forward. But in 2016, that was a key year because that was when Mayor Berry asked for proposals for the public improvement plans. And we submitted a proposal that was a 3-phase proposal asking for 1 nurse for every high school and 1 nurse for all the 2 schools for the rest of the schools. And we originally had thought about doing 1 nurse for every school, but we thought that was just much too ambitious, and so we kind of scaled it back a little bit to make it a little bit more palatable money-wise. And then in 2017, we did get the first phase of that expansion funded, which brought us 14 nurses and a supervisor position. Since then, the expansion has stalled every year. I always think, oh my gosh, this is the year we're gonna continue on, but then something always happens. So here we are. In 2019, we did our first full year of Medicaid reimbursement, and that is billing TennCare for the skilled nursing services that we provide in the schools. We aren't billing them, MNPS does, and so the money goes back to MNPS. And we were doing quite well last year, where we probably would have been able to add in a couple of positions based on the funds that we had received for that. But then again, budget stuff happened, and that money went to something else. So one of the things, though, I want to just point out is that I work very closely with the Director of Student Health Services over at MNPS. Her name is Nicole Boyle, and literally every project that I work on, she's working alongside me, and vice versa with the projects that she works on at the school. We have a great working relationship. So we are serving 135 traditional schools for MNPS, and traditional means that we don't have a contract to serve the charter schools. Charter schools gets their education funding directly, so they can choose to hire school nurses, which is why they're not part of the contract. Since MNPS gets their funding in a big lump, then that is passed out to all of the traditional schools, and so that's where our money comes from. This is our personnel breakdown. Right now, we are currently in a hiring phase. This is personnel if we were fully staffed. Right now, we're in a hiring phase, and we're trying to replace the nurses that we lost to retirement. We had a lot of nurses retire at the end of last year, and so we're trying to work to get back up to speed with that. So the focus that we are putting out there with our school nurses and the the thing that we want them to tell the schools is, I'm still your school nurse. And they certainly are. They certainly still are the school nurse for the students, for the families, and for the schools. Our nurses are working, a lot of them are working in the buildings. Some are doing some things from home that they can do from home. So it's a big variation. And we're doing a lot of the things that we always do. For example, emergency care plans, or ECPs that we call them. Those are plans of care for students who have medical conditions. And they are developed so that school staff will know what to do if the student has an adverse event and the school nurse isn't present. So the emergency care plans are, if you see this, do this format. We write them for asthma, diabetes, sickle cell, just all of whatever concerns that the student might have in the schools. Last year, we wrote about 10,000 of those. So it's greater than 10% of the student population, which is about 86,000 students that we write care plans for. And some students, of course, have more than one. The other things the nurses are doing is like just kind of planning out their spaces, looking at their space, deciding what the flow of the school clinic is going to be like once students return. They're doing immunization appointments. So students that are in 7th grade still need to have their Tdap in order to come to school, in order to come to virtual school. So the nurses are helping with that, because that is always a project where students start 7th grade without that immunization documentation at the school. So nurses are calling families, and they're actually making the appointments for these students and the families right directly with the health department. They're doing drive-bys. Since the health department is not doing home visiting, we don't want our nurses to do home visits either. But for example, we've got a family whose student was diagnosed over the summer with diabetes, and they're obviously trepidatious about sending their student back to school. They didn't have a lot of interface with the school nurse last year because it wasn't needed. And so the nurse made arrangements to come over to the house, be at a safe distance, pull down her mask so they could see what she looks like, and just talk about what it was going to be like once the student returned. So the nurses are doing a lot of that. They are calling parents and they're calling families, and just discussing what it's going to look like for their students when they come back, when everything is just a little bit back to what we're used to. Some of our nurses are navigators in the schools. So this is an MNPS program, and they identify every student has a navigator. Every student in school has a navigator. And what the navigator does is contact the student weekly just to make a connection, see how they're doing, give them some updates of what might be going on in the school. There's usually a script that goes along with this, and some of our nurses are participating in this. And that's to help students to, again, feel that connection to school, that they are still a student in the school, just like our nurses are still the school nurses. We're also doing virtual visits, or really kind of, I know that I said that the nurses are connecting with the students virtually, but also we're doing what would be thought of as telemed visits. So for some of our students that have diabetes, we are scheduling a lunchtime visit with them, just like we would do if they were at school. And so the nurse connects with them, helps them to calculate the carbohydrates based on what they ate, and calculate their insulin dose as well, and then look at the student's pen if they've drawn up an insulin dose, or what they might have entered into their pump. So that's, those are still just regular visits that the nurses are doing with students. And then initial investigations. And this is a project that we started, that actually Nicole and I started way back at the beginning of the summer. We worked with Leslie Waller in the epidemiology department to kind of develop a system so that there would be a fast track to reporting from the schools to the the contact tracing team and the case monitors. So Leslie developed this dedicated email box. And so we have, you know, a template that we use so that whenever we need to report that either a staff person or an athlete is COVID positive or is a contact, then we fill out the form and we send it in. And this, again, sometimes gets these people into the system prior to their lab value even getting reported to the health department. So what I think is the most important thing that the initial investigators, and we trained all the nurses to do this. So now it's not, you know, Nicole and I and Harold Finch at the MNPS any longer. The nurses are all doing these. And the most important thing about this, I think, that they're providing is that initial guidance to the person who's affected, because they want to know, what does this mean for my family? What does this mean for me coming to work? And so, the nurses will determine whether the person is going to be in isolation or are they going to be in quarantine, and what that might look like, what that time frame looks like. So that's kind of what we're doing in the schools. Then, of course, once it's turned over to Leslie's team, the people are assigned a case monitor, and then the contact tracing team takes over to dig into the history and contacting the people that they may have contacted. But that's part of the initial investigation, is saying, you know, who were the initial ones that are, or who might have been a close contact. So here are some key dates for the school system. Yesterday, contracted day schools opened up, and those are schools that MNPS contracts with to send students to. One school is named Genesis, so students returned to those schools yesterday. We don't service the schools when they're at the contracted day schools, so that didn't impact us in our program. But next week, on the 16th, Harris-Hillman, Merle, and Cora House schools are going to open for students. What we're hearing, the reports are at Merle and Cora Howe, about 50% of the families have chosen to return to in-school learning. At Harris-Hillman, it's much less than that, and our program will be servicing about 18 students. Harris-Hillman's, Cora Howe School and Merle, those are both schools that are more behavioral focused. Harris-Hillman School, many of you know, that is for students who have an IEP and they can be serviced at that site. They have special needs. Obviously, there's special needs students throughout the school district, but most of these students are also medically complex. And usually we have about 8 nurses at that school, but we're going to only have to have 3 right now, so the other nurses are out serving other schools. But that, there are a lot of skilled nursing services all day long for those students at Harris-Hillman. Then on the 23rd, a small group, 1,100 exceptional education students will be returning. And those are students who are unable to learn in the virtual environment, so they've been identified and will be returning to, not all the schools will be open. Students will be routed to specific schools for their education. And we're going to service maybe about 12 students. That's how that will impact our program as far as nursing services. But then after fall break, parents that don't choose virtual school will be sending their pre-K through second graders to school, and that's October 14th, I think. And but then there's no plans further out for third through 12th graders, although Dr. Battle said in her one of her speeches that or I think it was a presentation to the board, that she did not think that high school would be returning prior to winter break. So we will see them sometime probably in January, hopefully. And we could not do anything in school health if we did not have a management team. And their focus now is really supporting the nurses. Like everybody else, the nurses are nervous about returning to the schools or well, they've already returned, but to have students returning to the schools, what is it going to look like? How are they going to send students home? How are they going to protect themselves? How are they going to protect students? And so we're rolling out the information for that continuously, and we're doing a lot of repetition so that everything gets solidified in everybody's brain of what it might look like and what to do. But we had a great presentation at our beginning of the year in service by Laura Barnier, the director of nurses, because she just said, we're going to have to pivot. We're going to have to just make adjustments as we go along. And so we're doing a lot of meetings through WebEx, and the management team is meeting with their group. The supervisors are meeting with their group of nurses on a weekly basis. We have just like kind of a town hall meeting where I run that, and the nurses call in with questions and stuff like that, and we just have a chat and listen to what people are worried about. And we had some great in-services at the beginning of the year that really focused on how we would be able to best serve our students once they return, given all of the circumstances that have happened since all the things that have happened since March. And then, of course, the supervisors do that medication training. So at the beginning of June, Nicole Boyle and I developed a proposal to have a nurse in every school using some COVID funds. And that's gained a lot of traction, and Dr. Battle has really liked this proposal, and so she is very vocal about how she really wants to work towards having a nurse in every school, possibly starting with some COVID funding and then finding some sustaining funding to keep it going, because really, whether we have COVID or not, students need to have a nurse in their school. So our program is ready to start if we get the green light to go ahead. We've already developed how we're going to orient the new nurses and fold them in, and how we would actually start assigning nurses out. Generally, what we've always done in the past is we have put it where our greatest area of need is as far as procedures. But now that we don't have to be so procedure focused or procedure driven any longer when we're making assignments, one of our supervisors, Jennifer Cantrell, has made school profiles, and these profiles contain key data about health. They have the percentage of students who have a free and reduced lunch, the number of ER visits for asthma, uninsured, the percentage of uninsured students in that school. And so using those profiles and keeping equity in the forefront, that is what we're going to be looking at when we start getting people out of orientation and when we start to make assignments. So we're really hopeful about this, and I think that we're closer than we ever have been to achieving what is the considered to be the standard by the National Association of School Nurses and the American Academy of Pediatrics, among others, that there should be a registered nurse in every school. So our focus is to keep students healthy so they can come to school ready to learn. Nurses really are the leaders that bridge healthcare and education, and so every child does deserve a school nurse. And that's it. That is it in a quick nutshell. That's my contact information, and if people have questions, I am pretty sure I'll have an answer.
No. Well, first of all, thank you. I mean, gosh, to say, I agree with your very last statement. Every child deserves a school nurse. What a great way to end it. And if anyone's to take anything from this, that statement, I think holds a lot of weight. And so thank you for everything you and your team have done. I will open up the floor for questions, and if you just want to say something, or please raise your hand, or just say something. It's there, and if maybe you can quit sharing the screen, that way we can kind of see everyone. That'd be helpful for me. So, anyone have any comments? And if not, I have actually a comment. Thank you. My one question specifically is when it comes around mental health and support for students as they come back, or students now. Did your what's the involvement of your program in that, or resources available, or is that beyond the scope of this discussion?
It's not beyond the scope. I mean, certainly we aren't mental health professionals, but we all have taken coursework when we were educated to be a nurse. And school nurses are very important and key in that, which is one of the things that we really focused on in our in-service. Is we had a presenter come from the school who really was very knowledgeable about working with, about trauma-informed care, and gave us gave the nurses some real practical points of how they can, work with students who have been affected. I mean, since we've been out of school, there's been COVID, families have been affected, maybe family members have died, kids are scared, there's all sorts of attitudes. The Black Lives Matter movement has really come to a huge forefront, and so we want to be sensitive to all the things that kids are experiencing in their homes. And one of the really key points that I took away from that presentation was really understanding of, the kid has a much different lens than the nurse, and trying to just be cognizant of that and working within that context. So I think that, yes, we've done a lot to prepare our nurses for dealing with the mental health, and there's a whole system in place for referrals and things like that within the MNPS system that we're a part of, so that we can guide students to where they need to go to get the resources that they need. And that's all part of, too, why they started this Navigator program, to help meet these mental health needs of the students.
Okay, thank you for that. Anyone else would like to ask or give any comments?
I actually have a question. And I don't know if you're going to be able to answer this, Lisa, but maybe you can. I'm thinking you've probably been in conversations around this. And I appreciate what you said about equity in the forefront. So I'm thinking about households of students, households that have students at different schools. So if a child at one school has to go home because someone in their class tested positive and they have to go home and self-isolate, how does that impact the siblings of that student that attend other schools? How is that communication happening? Sort of, where are you in understanding a potential strategy for households that have multiple students at multiple schools and one particular student has been exposed?
Right. So we're actually doing a little bit of that right now, because we are, a lot of times just in conversation, when the teachers are having conversations with parents, parents will, say, oh, my husband has COVID. And so now we're isolating. And so when that information gets funneled to the nurse for that school, because we are getting notified about that, they will have a conversation with the parent. They will find out where are these other students located, and all of that information is part of that initial investigation. But if a student were to be sent home because they may have been in contact in school A, that the other students then are considered contacts of a contact, and so there is not a lot to do for those students unless the original, the siblings, unless that original student became positive. So the other students don't necessarily have to stay out. But when it gets down to that real, all of those little idiosyncrasies, we definitely just, which is another reason why we have that dedicated email, because we ask Leslie's team, okay, what do we advise here? So while we do the initial investigations and can do those real simplified ones, when it comes digging down that deep, we say, oh, what do we tell them? And then we make sure that we are giving the correct information and that we are going to take care of all of the students affected, in that household.
Thank you. And then just one other question. At the top of your presentation, you mentioned that you had about 77 nursing positions for the 135 schools. How many nurses do you have right now that are on staff?
I have 68 nurses. We've got 2 that are in the hiring phase. One, I think, is starting next week. And so in the usual school year, each nurse has between 1 and 3 schools. We've got some specialty assignments where if a student has a trach, then that nurse is assigned to only that school, and she has to remain there all day long for that student, in case something should happen. And then, like I had said, we've got 8 nurses usually assigned to Harris-Hillman. So when you look at the numbers and you think 77, well, that's 1 nurse for every 2 schools. It doesn't really work out that way. But we're at 68 nurses now. And since the Harris-Hillman since those students haven't been in attendance, we've kind of moved all of those nurses out to other schools. So we're able to really kind of maximize the amount of nurses that we have and being able to adequately serve the students and the families in this virtual space. Now, once we start to return to school, we may try to fold in some agency nurses to supplement what we're doing, just to make sure that we are going to have a good set of coverage for the schools.
Thank you. I really do appreciate the work that you're doing.
Oh, thanks.
How long, Lisa, have we talked about having a nurse in every school? Well, way before 2016, before that, Mayor Barry's call to arms came along. So, I mean, it's just been forever. And, but I feel like more people are listening. And so, with every year, I'm always hopeful. I'll always say. It sounds like COVID, it might be a sunlit edge, if there's any, a sunlit edge of COVID, that we might finally see a nurse in every school. So thank you.
Yeah.
All right. Anything else? Well, Ms. Nistler, thank you for your presentation. Very grateful.
Yeah, and I just want to put, of course, I'm here every day. If anybody has any questions, then they're welcome to, email me, call, and ask. And if anybody ever wants to just go alongside a school nurse for a couple of hours, we're welcome to do that too. Or see what goes on at Harris-Hillman. So anytime that anyone's interested, just let me know, and we'll make arrangements to make that happen.
Great.
And I really appreciate you having me here today.
Feelings mutual. Thank you for being here. Thanks. Mr. Diamond, you got a couple of things to discuss, so why don't you take your section on grants and so forth.
Sure. Dr. John Gere, we do not have any applications up before the board this month, so I'll move on to the grants and contracts. There were 5 items included in the advanced packet, as well as 2 additional ones added today. Item number 1 is our child care agency immunization audit grant from the state. It extends the term and increases the funds. Item number 2 is our state Healthy Start grant that also increases funds and extends the term of that grant. Number 3, as well as our fetal infant mortality review grant, the FEMR grant with the state, also extends the grant and increases funds. Item number 4 is an MOU with Metro Fire for the substance abuse reduction program as part of the high impact area opioid grant. Item number 5 is with the mental health cooperative. Another year of that at $440,400. The 2 that were added item number 6, and I apologize for not having that this is with the state of Tennessee on there, but that is the grant with the State Department of Health for chronic disease prevention. And item number 7 is an amendment to the TB trials consortium contract between Health Department and Vanderbilt. And I'll be happy to entertain any questions.
I have 2.
Okay.
Jim, I don't know who's with you there or listening. You may not be able to answer it. The Healthy Start home visiting, since it is home visiting, how is that impacted by COVID?
I would have to ask Tina as well, but I think they're doing very limited visits in person. I don't have Tina with me. I'm alone in my office here, and I don't believe she's on the call. But they are, their people are working and working remotely, but I believe they're very limited in any home visits with anything that they're doing.
So that's why, since that is such a home visiting kind of program,
right?
Will that money still run out next year on September 21? I mean, it just seems so important to have these home visits, and I know they can't happen now, but to...
Sure. This is one of these grants that we've had seemingly forever, and most of the money included is salaries and benefits, and the employees are still working, so the money's not being lost or not used. But this is one of those grants that we just seemingly get every year, and continue to do that really important work.
Mr. Diamond, I have Tina has arrived in my office. I'll let her answer that. Just one second. Come on in. Go right up there.
Hi, this is Tina. The Healthy Start grant, as well as all of our other home visiting programs, have been doing most of their work virtually. They do it by telephone, by email, and so we're continuing to serve our clients on a regular basis, and so we're just not able to go into the home, but we can drop things off, we can have things signed, we just drop it at the door, wait till they get it, make sure everything's okay, and that's it. But we're not going into the home and doing visits on a regular basis.
Just for clarification, I think that this is what you just meant, but you are making regular contact with those persons. It's not in person.
Absolutely. Every month, we are making regular contact. And we're still enrolling new people as well.
Right.
Okay?
Thank you.
Thanks.
All right. You can call me if you need me.
Okay.
I'm in my office.
Okay.
All right. Any other discussion on any of the grants or any of the applications?
Just out of curiosity, on that fetal infant mortality review, Marguerite, Dr. Johnson wasn't she representing us on that?
Yes, she was, and I don't think she's been replaced as far as the board is concerned.
Yeah, and I think that's probably okay, Tina. If you would just let someone know if you feel like it is important to have representation. She just, I know, had a very specific interest in that. And
breastfeeding.
So
Dr. Caldwell said that she has continued. So, he attends the meeting, so she is continuing.
Okay, perfect.
So is she representing the board?
No, she's just representing herself as a physician.
As a pediatrician. Okay.
Okay.
Mm-hmm.
Very fine. Thank you.
Okay.
Any other discussion if we go around this? All right, hearing none, I would welcome it. Dr. Caldwell, can you turn on your camera? I mean, I appreciate that. All right, and if there's no more discussion, I'd like to have a motion if people would approve this or not.
Move to approve. Second.
All right, that's Ms. Etherington. Ms. Franklin, all in favor? Show your hand.
Aye.
Aye. All opposed? I'm assuming Dr. Smith is an aye, since he's just a green screen there. Yeah. All right, thank you, Dr. Smith.
Just a warning, I just 29% of battery capacity, so I may die, but I'm still in the room where the.
All right, got it. All right, thank you. Motion carries.
We're working on it.
Thank you very much for that. I think we are at the report of the director.
Hey,
Go ahead, Dr. Hall.
just doing a sound check here. Can you hear me okay?
Loud and clear.
Oh, okay, thank you. The first thing I'd like to do is just bring to your attention that we've had a death of our health department family, Marilyn Gregory, a dedicated Department of Health employee for more than 40 years and a friend to many of us. She worked in the East Clinic, passed away recently, and I'd like to ask if the board might want to try to provide some kind of recognition of her service and her passing while she was still an employee.
Yes, we just found out, I just found out in the board packet that she passed away over a month ago. So my condolences to her family, and yes, I support board recognition in an appropriate manner.
Are you thinking of writing a letter for her family?
Write a letter, and I know, and I also heard, and I just wanted to say thank you to the employees of the health department that they raised $1,300 and provided that and presented that to her family. So thank you to the employees. Our condolences to her team members, our condolences to her families, and Carol, you're so good at formalities. I'm going to lean on you to sort of help us think through how to appropriately recognize.
I'd be happy to, because, I used to see someone out there, and they allowed me to use their facilities to see someone, and I remember her, and I was shocked to hear it. So Dr. Caldwell, we'll work on that.
Yeah, I might even think that an employee of 40 years might deserve some recognition through some special resolution of some kind that her family might really appreciate. So just as a suggestion. So, but however you feel appropriate, I'm happy to feel.
So why don't you, Dr. Caldwell, bring a recommendation to us and do the work that entails to do that. I think we are all sounds very supportive of that, and perhaps we can formally approve it at the next meeting. Then, if does that sound like a reasonable plan, everyone? Because and I think you're right. I mean, if somebody's 40-year employee, to honor her legacy it would be a really nice gesture, and I hope her family would appreciate that as well. So.
Thank you. I'll work on that with Carol.
Yes.
Okay.
Yes.
Thank you.
I'm sorry. Why don't I double back with you, and maybe Tom can also be a part of helping us draft that, and
Sure. Okay. Thank you so much. I just wanted to take a moment to start with that. Anything else on that?
Okay, thank you.
Okay, thank you. So starting with a review of COVID, we are providing the board members with daily information, and in addition, I still provide an approximate weekly update to you to fill in some information and try to focus some attention on some other items that we're doing. Good news is that the numbers are lower than they were at our last board meeting. They continue to trickle lower and sort of hovering sort of at a steady state. We had this Labor Day weekend be something that we worked very diligently on to try to maximize enforcement efforts. And over the last 3 weeks, there's been a new infrastructure with the leadership in the mayor's office and with Bob Cooper, who's the director of Metro Legal, overseeing approximately 10 different Metro agencies that meet at the beginning of each week and at the end of each week to review plans for the weekend and debrief how the weekend went. This past Labor Day, there were a lot of people in the Broadway area Friday, many more on Saturday, and some of the reflections on people who were there were feeling that it was almost as if it was a pre-COVID type of atmosphere, at least between 4th and 5th Avenue. That was a great concern to me, because even though we had taken preparations to provide for extra social distancing by having metal fencing on either side of Broadway from 5th down to 1st to provide an extra lane for walking by where people would normally park. It was still inadequate for the crowd we saw Saturday. So in observing this and reaching out to the mayor's office and others on our enforcement team, the mayor made a determination that on Sunday there would be a pilot test between 6 and 11 to close Broadway down between 4th and 5th Avenue. Once that occurred, there was an ability of emergency vehicles to freely flow there because the previous night on Saturday it was very packed, even not only with people but cars. So it was even a safety issue for emergency vehicles not being able to get through. That was relieved when we were able to have Broadway closed between 4th and 5th. More importantly, when I arrived on the scene there just after 6 o'clock, that I immediately recognized that the sidewalks and the people waiting to get in these facilities, their behavior had not changed. They were still kind of packing together. So I worked with each one of the restaurant and bar owners to determine a different course of action. And that would be that we would determine that sidewalks would be for walking and only for people passing by, and that if we're waiting online for to get into a particular facility, the line would begin at the curb and then extend straight out to the middle or beyond the street. Each one of the businesses very quickly accommodated this and did it in kind of different ways. They learned from each other, and you may have seen some of the images which showed that once you do that, not only do you relieve the sidewalks of congestion, provide more social distance for people walking, you don't have those individuals crammed up against the building who are waiting online and cramming away from people trying to walk. So those people waiting online to get in now had the ability to space out. And there was a more natural social distancing of those people online just because there was more room on both their right, their left, and the front and the back. So this was deemed by the police to be successful, with the exception that they needed a couple of traffic control officers. I've been working with each of the owners there to determine how we could listen to their concerns, as well as try to see if we could potentially pilot this again this weekend. And we learned at the mayor's press conference today that the Tennessee Department of Transportation has approved an additional 2 days of trial of this for this Friday and Saturday between 6 and 11. And I continue to be in touch with a number of owners there. We're not going to be closing beyond that just now. There are two, for a few reasons. One, not every place is open yet. And I think we can accommodate the crowds in other locations a little differently. So I'll be working with Honky Tonk Central, which is just south of 4th Avenue, to get them also to use that extra lane to have their patrons start to wait on the curb and use that metal fencing as their waiting area so that the sidewalks can be used for walking there. And similarly, Kid Rock's is just south on 3rd there, and I'll be asking them to do the same thing. So hopefully that will relieve the congestion without the need to continue closing the whole road between 4th and 3rd or 3rd and 2nd, at least at this time. So I really think this has been a major positive step, and we're treating it as a pilot program and looking forward to seeing how this weekend goes. So let me just pause for a moment there to see if there are any questions on that, because it's sort of a hot topic.
Yes, Dr. Cole, I don't know that I don't want to create any more problems for enforcement than we have presently, but when we had our update call, I discussed with you that I had recently visited a small resort town where there's a lot of foot traffic, a lot of pedestrian traffic, and where that traffic occurs, they have a mandatory mask order outdoors in that section only. And I think presently, we sort of leave it up to the discretion of the individuals as well as the police officers enforcing it, what is appropriate social distancing. So if a mandatory mask order for certain parts of the city, and Maysville or Broadway is probably the only place, might be something to consider. And I don't know that it's the right answer, but it might be something that we want to consider as we begin to open more establishments along there.
Yes, thank you for that feedback. And that's making me think also of the pilot program we've done at the Fairgrounds racetrack. You people there, even though there's more people there, they could be socially distanced, meaning 6 feet or more away from each other, but we require them to wear face masks even if they're socially distanced because there are so many people in that one particular area. So I think that's an important suggestion and something that we could think about, as we have sort of carved out areas where they can't be walking around with their drinks, open drinks. Perhaps we could say, in addition, whether or not you're socially distancing, these areas could require face masks. That's not the way it is right now, as you note, that if people are over 6 feet away, then they don't need to wear a mask. However, once the crowds come about, we know that as people are walking in and out, they're sort of in and out of social distance. That's why we require the mask. So thanks for that feedback. Any additional feedback, and then I could move on?
Please move on.
Thank you so much. Okay, so our hotline, which has been in operations for a while, the Community Assessment Hotline, has now a partnership with Hub Nashville. And so we're working with Population Health Tina Lester's group and our behavioral health group to continue to lead that. Thanks to Laura Varnier for all of her work on all of these months to keep that running. But the hotline continues 7 a.m. to 7 p.m. 7 days a week with an operator available. And so we've expanded Hub Nashville's capacity to be able to work with us to continue that. We're really pleased to be able to continue that. The results line, we are in discussions with a company called Extend, and that contract is in development. We hope either by September 18th or September 25th to have that transitioned. This is the same organization that does the results for the State of Tennessee Department of Health. So they also are very familiar with our previous lab that we used, AEL, as well as the PATH group. And so we are looking forward to a seamless transition with them. Also, regarding COVID, I want you to be aware that our at-risk population continues. We continue to work closely with them, with our partners, and we are continuing to enhance those efforts. We may be seeing now some success in reductions in numbers, at least if you look at the latest heat map, because there's some activity in another part of the county now, which happens to be at the state prison, it may appear that at least those parts of southeast Nashville that had been a hotspot have rapidly disappeared. Please note that you have to take it into context that each of these weekly heat maps are a result of the total cases of that particular week. So while we're seeing a reduction in cases all over, primarily, we still are not letting up our efforts at the at-risk Nashvillians communities. We're continuing to do extra testing there, and I was really happy to see our staff this past weekend at Plaza Mariachi, for example, doing extra testing on this weekend as well. That's just one example of how we're continuing to do that. Just looking at some of my notes here. As for our enforcement efforts right now, the new health order requires that any events between groupings of 25 to up to 125 need to get approval through a written submission to the health department of that event, as well as monitoring. So that system is the infrastructure is being built. At this time, we're doing our best to monitor the Director of Health at Nashville.gov website, where all of these plan submissions are being directed at this time. And we're working, and thank you as well for extending that emergency order, because that provides us some flexibility. And let's say if an event is for October 1st, 2nd, or 3rd, we can feel comfortable with our approval of that without worrying about an expiring public health order. So that was very important for us. I want to thank you for that. Moving on to some other issues, let me pause for a minute to say that the vaccine trials with COVID, there was a highlight today on the mayor's press conference. If you missed that, I'd encourage you to review that online. And you've heard that the AstraZeneca study was paused. That's all we know right now. And so we're on hold with that. Clinical Research Associates also has the Pfizer study. So myself and the other doctors will be reviewing that protocol. I've previously sent to the board members the information that's available at the NIH website, so you have that as well. Since their target goal is only 200 patients there, the involvement of Dr. Bailey, Dr. Shaw-Kaikai, and myself would be limited if at all. And so if we were to start seeing patients, that would be something that would not happen till next week, and also would be adjusted for the very small number of patients they have. As we hear more about AstraZeneca, we'll let you know, but that was really the only 2 studies that Clinical Research right now we're signed up for, and you'll be able to hear more details from the mayor's press conference today on that. I do have Dr. Gil Wright here. I'd like him to give a quick update for me on my behalf for the COVID vaccine approval, hoping that we do get a safe and effective vaccine that makes it through the clinical trial successfully and that gets approved. We are already planning with CDC and the state health department on next steps, and I'd like Dr. Wright to provide information on that, and I'll finish my report after he talks. I'm just going to adjust this for 1 second. And my screen is right there, so thank you, Doc.
Good afternoon. We had a first meeting here this week regarding the vaccine, and we're hearing that it could be available as early as first part to middle of November, planning accordingly. We are waiting right now for the state to finish their submission to the CDC so we have final outline of who would be in first tier, second tier, et cetera. But I've already talked with Chief Swan. We'll be meeting with them to consider whether we stand up a place where we can do drive-throughs that will be separate from our assessment centers. I have met with Steve Kane, who's in HR downtown, to begin to investigate all of the departments and how they would tier out their individuals that are essential personnel. I mean, obviously fire and police, but there's the judicial system, there's beer board and codes are important because they're helping with enforcement, for instance. So we're looking at all that. And I have a short meeting tomorrow morning with Kristen Wilson just to kind of inform the mayor's office of the start of this and such. So that's where we're at with it, and we'll let you know more as we know more. You're back.
See if there are any questions.
Okay. Any questions? Okay.
Thank you. Okay, thank you, Dr. Wright. So that concludes the COVID portion of the director's report. Moving on to other issues, I believe the board is reviewed the contract for Dr. Rand Carpenter, who's will be our new epidemiology lead to head that unit. That's one of the 2 parts of the organizational structure that we've already been crystallizing. Our strategic planning and evaluation unit with Dr. Celia Larson, which is helping us to prepare for the Public Health Accreditation Board resubmission, which we have until the middle of 2021 to do that. She's also helping us lead the strategic planning effort, which our strategic plan concludes at the end of this calendar year. So we'll be starting in October, rapidly reformulating that so that by January, we hope we'll have the next 5-year strategic plan. And with that, I'm going to be using the time between this board meeting and the next board meeting to finalize my thoughts regarding the organizational structure and organizational chart for the department. I've discussed this with the senior leadership, as well as I've reached out to everyone in the department, asking anyone who would like to help me think through if we could even have a blank page, what would they do to redesign the department, or what do they think works well, what's not working well, what historically has worked well. So I had about 30 people raise their hand, and I've just about concluding now series of WebEx meetings with them, and there are each of those teams that have come about. I'm going to continue to work with them as teams to help me with the rollout process over the next month. So I can give you a sense of some of the themes of what I'm thinking of for the organizational restructuring and chart that I'll present to you in October. And a few items. One is, right now I have 13 direct reports. That doesn't work for me. I need to reduce the number of direct reports, so I'm thinking that through and trying to get as much feedback as I can and what way I can do that would work best for me and for the department. I also want to provide an enhanced interoperability and an infrastructure and a foundation for the department, which I think right now there seems to have been a lot of decentralization, and the EPI team has been one of those, which I think I've seen sort of elements of that elsewhere, and I think we just focus to really develop as strong a infrastructure, skeletal structure as I can, so it can work for everyone, but to have more of a seamless interoperability and a real support network for all the programs, as well as the people in them. And I've been really pleased and impressed by how the face mask distribution efforts and our monitoring of our pilot programs like the Fairgrounds Racing and the Live Nation Drive-In has brought people together from all over the department who have signed up to volunteer through these opportunities, whether it be school nurses, WIC program, immunization coordinators, CHANT program, environmental health. They come together and they put on those yellow shirts and those public health hats. It really bonds them in a real special way. They get to know each other, and it's really helped me understand them, get to know them very well, their programs, and what they think is working or not working. So even though I've had these sort of structured conversations, I've had many hundreds of hours of unstructured conversations to help me through my observations now. Yesterday was the 6-month anniversary of my very first day here. So I think it's just the right time now to move forward with this. In addition, I'm trying to think of how I might be able to cluster some types of programs and services that kind of work well together. So I'll be continuing my conversations with each one of you, board members, between now and October, so that by the time of our next meeting in October, that you will all have had a preview of some of my thinking. I've been able to share some of that with you all already. So with our regards to some of our other programs, our WIC program continues to operate remotely, and we're really happy that our numbers are very high. We're doing a great job in that way. I have not heard that it's going to be extended beyond September 30th, although there is a possibility that it may be extended as sort of virtual WIC all the way through December 31st. I did participate as part of a census parade with other agencies in the metro area, as well as federal and state agencies and I drove the WIC van to promote WIC and getting people to fill out the census in the very shortened time frame that there is. So that was a great opportunity to participate, to let people know how important the census is for public health, and also to promote our WIC program. And if you know that van, it's got really wonderful pictures of children and promotes breastfeeding and nutrition and our number there. So hopefully some people saw it and were inspired to learn more if they're not already a participant with WIC. Our dental program continues to still be working well, where we're providing care to patients here at Lentz with enhanced sterilization protocols. We have aerosol mitigation, additional PPE, social distancing in the waiting area, and we also added a new person, a temp person for a sterile technician. So somebody, their job is to sterilize the area. So working with Dr. Pardue, who you know also is a dentist, in her leadership, safety is paramount for our staff, and that seems to be working well. The staff's comfortable, the patients are comfortable. The school-based dental team is not able to see students in person right now. However, that's not stopping their work. They're partnering with schools to provide and distribute oral healthcare kits for the students, and they're also helping to create lesson plans to provide oral health education virtually. Really grateful for that team to be continuing. Of course, you heard Lisa give that great presentation for school nurses and how wonderful it is with the silver lining of COVID to know that Dr. Adrian Battle now has been public on many occasions saying that it is necessary to have a school nurse in every school. Really wonderful to have that recommendation at that level of support, and even hearing some board of education members as well as members of the COVID Financial Determination Council for the CARES Act funding, understanding that we need a school nurse in every school, not just for COVID, but for every day, even beyond COVID. It's not just a COVID thing, but had we had it, it might have helped us feel more comfortable getting back to school sooner. It's just one small step in that direction. As for vaccines, the flu vaccine is starting. Some of you got yours today. Thank you so much. I'd like to really thank you for getting your flu vaccine, standing up there, being a public health leader and demonstrating that flu vaccine is important. It's available. The public will be able to get their vaccine very soon, wherever they feel comfortable getting it, either at their regular doctor's office or pharmacies. They're coming into town now, these flu vaccines. So today's September 10th. Please get your flu vaccine if you haven't yet. It is so important now more than ever. They'll be available through 3 different programs from the Department of Health, the Vaccines for Children program, 317 program, or the self-pay program. And we do have a flu truck available for public health staff so that they all can receive their flu shot on September 22nd for those public health staff that are listening in to today's meeting. Also, September 23rd here at Lentz. Also, Woodbine, East, South Nutrition, and our animal care program at MAC have their own set days to provide their flu vaccines to staff. And if they miss that day, we'll catch up with them. We will also continue to give flu vaccines to all Metro employees in a drive-through fashion October 5th through 8th, and our locations are being finalized right now. Now, finally, Fight Flu Tennessee, this is a statewide flu vaccine program, is set for November 19th, 2020. Even though you already have your flu vaccine, I'd encourage you to put that date on your calendar. It would be great to have as many board members as can to stop by and give their support. Fight Flu Tennessee, November 19th, 2020. There'll be free flu vaccines available to all the citizens of Davidson County and at all public health clinic sites from 9 a.m. to 3 p.m. And I believe we're going to be using the Nissan Stadium as a drive-through flu vaccine clinic, and that will help us pilot that for potentially using that as a model for the COVID vaccines. So really pleased about that. The animal care program, some of you know I've been working to create a first walk adoption Music City experience, and that has progressed We've gotten the Music City Convention Center, Mr. Spirit in to help provide a sound box that they have downtown to be put at the Mac Animal Care area so that there can be a song played, a special song for a very first celebratory Music City Experience First Adoption Walk. And we also worked with the Opry House. We had some of our newly adopted pets on stage at the Opry in the circle getting their pictures taken, and some of those special pictures will be adorning these sound boxes. So just one way that we're trying to build and partner public health and Music City, and with some of our other partners that we're getting to know so well throughout this COVID process. I know that when I spoke to Mr. Frederick previously, he asked that I provide an update also on the End the Epidemic and on HIV, and I'd like to ask my staff to prepare to have a presentation on that for you at next month. And also, of course, provide any additional information that you'd like, and I'm happy to answer any questions now.
Yeah, thanks, Dr. Caldwell. I have a few things, if I may take Chair's prerogative first. First, I want to highlight or make as Chair say, when it comes to the strategic plan as well as the org chart, the board needs to be extremely involved in that. The board will need to approve both of those, and just that's at least for the next hour or however long I'm still chair, assuming I'm elected or not. I think as a board member, that is critical for me. And so I just want to highlight that to my fellow board members and to you specifically, that no movement on either of those fronts as far as implementation needs to happen. And I think as you verbalize, and I appreciate that, is we need to all be very involved with that, because that's exactly why we have a board, right? It's oversight over those really critical things. So just want to put that out there on the record first.
Well, I'm going to be rolling it out over the next month. So that's why.
Rolling out what? What do you mean?
Well, the organizational changes.
By rolling out, you mean, what do you mean by rolling out? Can you elaborate the word rolling out? Well,
I've had some one-on-one conversations with you that between this meeting and the next meeting, I'm going to start making changes.
Okay, well, let me clarify what our private conversation was in public. There will be no implementation of any plan without approval of this board. That's how we did it of a org chart, because that's how we did it previously when Dr. Long did it. I was not here when Dr. Paul did his, but I would assume that's part of the that's one of these things that we do in our prerogative as board. So I appreciate you having a plan, us talking about it, making sure the leadership team is on board, get input. But I guess that's part of my reason I want to put this out publicly is we as a board approve the org chart prior to implementation. That's how it was done. And the one other time I've been a part of the board, Dr. Long. So that's number one. And same thing with strategic plan. So I just want to be very clear. Before I mean, I'm only just telling this so we're all on the same page here. That's the only reason I haven't verbalized.
It will impede my ability to roll it out.
As your board chair, I'm now being more clear. You will not roll this out until you've discussed it with everyone between now and next month, and then we can vote that, hey, we're going to implement this starting October, whatever. I mean, we discussed that in private, and I'm now verbalizing it in public. I think that's how it's been done previously. And if I'm wrong, if somebody on the board, if somebody on the board, if I'm wrong about how we did it previously, I by all means am happy to be corrected. So please, somebody correct me if I'm wrong about how we previously did it.
I just want to clarify our conversation, Dr. Jackson.
Hold on, please. I believe Carol, were you saying something, or is it?
Nay. Yes. When Dr. Long was here, she had a very minimal change, and she did bring that to the board for approval. So I think that is, yes, there is a precedent that's been set for that. In addition to that, I think we have a tradition of being able to communicate with bureau directors about the work that's going on, and that's been going on at least since I've been on the board for well over a year. So we have that situational awareness of how things are happening. So Yes, we do need to be involved. We do need to be aware of what's going on. So I do support you on that. And then lastly, if it makes it neater or more, if it makes it very clear for us to have a board vote on that today, maybe that's something that we need to consider, because this is important, and I agree with you that we do need to have oversight with this process.
Carol, you're the only person with limited extended experience.
Well,
Sorry, Mr. Frederick, would you say?
Carol is the only person here who's been around long enough to have seen it with multiple directors, so I wanted to get her input.
Yeah, me too.
Okay, well, I think that it's pretty safe to say that from Dr. Paul and then the very brief time with Dr. Long, it's proven to be that the strategic plan is a pretty critical item, and there are lots of different views on what a strategic plan is supposed to look like. And so it makes me a little nervous, given this past history, to hear you say you're going to roll it out before we've really had a chance to see it, and to some degree hear from some of the ELT. And that doesn't mean that I or anyone else wants to delve into the operational aspects of this, and it sounds as though you've had a lot of conversations with them, Dr. Caldwell, but in order to really support you, I think it is extremely important for us, particularly at this point since you've been here 6 months. And so much of the time has been taken up with COVID, and we've got all of these other services and all of these other programs that are falling under the various bureaus. It really is beyond important to have an opportunity to view it next month.
Right. I just wanted to clarify my conversation with you, Dr. Jahangir, because
I'd like to ask Carol a follow-up question, please.
yeah, well, I'd just like to clarify
From my perspective, workplaces, organizations that I'm familiar with, you're right, you do have a strategic plan that drives your org design.
Right.
And I know it's time for us to redo our strategic plan, and COVID has taken up in the tornadoes.
Exactly.
So I agree with that particular process, and that's what's happened in the past, correct?
Yes.
So the strategic plan drives the org design, and then after the org design, the proposed changes come to the board for us to approve.
Yes, and I'm sorry that there aren't others who've had this long history, but my remembrance over these years has been too that sometimes the strategic plan wasn't as inclusive in terms of having a lot of input from senior management, and I think that posed some issues in the past. Also, that sometimes it was not really followed particularly closely, and that created some problems.
And we also have to have accreditation that hasn't even been mentioned.
That's true. So
yeah,
the accreditation piece, along with the strategic plan, are two really important things that we need to be up to speed on. I'd say definitely sooner rather than later.
All right, Dr. Caldwell, please elaborate on Mark's previous conversation. I'm sorry to thank you.
Yeah, thanks. Now, I understood that you had directed me to give these sort of general thoughts to the board, that the strategic organizational chart would be presented in public to you in October, so I would have a chance to roll it out between September and October. So, well, just to clarify, say I can roll that out through the conversation so that when I present it to you, it will have been rolled out but not implemented until that vote. So I understand that, and I'll agree to that. So I think we're all on the same page with that. I'd want to just clarify that so we're connected and communicating, and I understand. I'd just like to emphasize that, you know, you'd asked me to be here to set a priority and a vision. You've directed what that vision is, and I think that I need to have the flexibility to design the organization in a way that works best for me, so that I can implement that vision. So I just leave that to you as thoughts, and I know that we'll all come to a resolution. I think it was just a little miscommunication on what we meant by rollout.
I hope that's right, because I'm pretty clear. So rolling out to, when one says roll out to me, it means implement. So if you're talking about discuss, present, that's different than implement. With that being said, Mr. Frederick, I saw your hand.
My question was the same. I wanted to understand the definition of rollout, and if the definition is indeed discussing it with the various board members on your monthly update and sort of socializing the idea, I'm all on board as long as it is not implemented prior to our approval.
Yes. Well, with that in mind, I'd like to at least then ask, since I thought I've already implemented, but I guess you need to approve the strategic planning and performance unit and the EPI unit, because that is already being implemented. So I guess in keeping in aligned with what you're asking, I asked for that to be.
No, Michael, please stop. With due respect, I think we're talking about two different things, please. I don't think anyone here is saying, hey, if we need an EPI unit, roll that, implement that. When I hear org chart, and you showed me a draft, I mean, and in full disclosure, there's no secret here, I'm thinking org chart, right? I mean, we're talking directors, we're talking this, we're talking that. Putting together a team or two to address an issue as it reports through your current hierarchy, to me, doesn't need micromanagement by the board per se. So you don't need approval for that, in my opinion. But what I'm saying, a fundamental structural change in which you're taking 13 very seasoned executive people, and then now proposing perhaps 5, I think takes a little bit more dialogue, and that's what I'm saying. And I think so. Please don't replay the words that I'm using to justify any delay or paralyzation of progress that needs to happen on certain things. And so please don't play those games with me. And then that's what I want to be very clear about. Period. So
I didn't think I was. I'm just trying to ask for your approval.
There you go. I was pretty clear, I think.
So where are we here? Are we on the wavelength, Dr. Caldwell? You hearing from the board a real concern about wanting, before dramatic change takes place, whether you're considering it dramatic or not, it sounds like there's pretty specific changes. So are you okay with our request to review this, even though we will all be talking with you as we normally do? But as a group, we want to see it.
I would prefer to have the ability to reorganize the department as I think it's important, and then to get your approval. I'm not going to propose anything that's out of line with achieving the vision. So I need to have the ability to do that. And I think that, for the October meeting, that's fine. But I think at the end of the day, it has to be my choice to determine how I want to structure the department. That's where I am a little, very clear on that. That's really the role of the director. You hired me. I need to structure it in a way, because if I can't structure it in a way I think works for me, how will I be able to successfully achieve the vision that the board sets out?
Let me ask you this, even though I think we're all agreed we really want to, in October, review this. Can you be really specific about the type of input and the way in which you receive the input from your teams?
Yes, I talked about it at the executive team meetings. I've spoken one-on-one with each of my direct reports on more than one occasion, and I will continue to. I've reached out to our 600 staff, asked for help, and I've had structured team meetings with them, about between 3 and 5 each, up to 30 people who raise their hand. In addition, I've had hundreds of hours of unstructured conversations with staff from all across the department. as well as staff, even in other agencies, to understand how important our interdepartmental relationships are. And then, of course, our inter-community relationships. So all of this is going into my thoughts about what's best for me as a director and as a leader, what works for me to be able to have an organization that I believe can execute the vision that will then lead us to have the strategic plan based upon that organization. So that's why it's so important that October be the time that we review and approve this, so that the new strategic plan can be based on through that new structure. So,
thanks, Doug. One thing I want to highlight, I did consult with the charter while in this thing, and I want to highlight to ask your question of your prerogative as director, as director, and my prerogative as board chair, and the five others here as board members. The charter requires that the board is presented with a plan of organization for divisions, branches, and subdivisions to the council actually for approval by ordinance. Also, newly created positions must be approved by ordinance, and this is per the Metro Charter, Section 12.1. So yeah, I want to be very. I just want to be very clear.
The charter is changed, so I'd rather just the board approve. I would think that you're looking for charter changes. I would rather the board.
I'm not saying charter changes. I'm saying the way in which we are. The way I am. I think I've proven through this time. I try to play, call balls and strikes and follow the rules. The way that the charter is, and I believe I can actually ask Mr. Smith as our counselor, legal person here. Sorry, my terminology may be off. Essentially, the gist of what the Metro Charter mandates us to do mandates us as a board is to approve changes in org chart. Period. Would that be a fair statement, Mr. Smith?
Yes, it's your duty. Actually, it's specified as a duty under the charter to approve that and then present it to the Metro Council for approval via an ordinance.
Okay.
So it's a duty imposed by law.
And I in the Metro Charter, typically, if we as a board approve it and have the oversight, they're usually supportive of such changes. So, and then it may not be. I mean, I can't say what the council does, but I guess my point is I want to be very clear. This is not me being overstepping my authority as a board member, which I don't think I was, even if there wasn't a charter thing. This is me following the rule of the law of the city of Nashville, which all of us have to do. So all I'm asking, I want to go back to my original ask, is great as a director. Yes, I agree. You just create a department as you so feel would be most effective. It can't be rolled out until we as a board approve it. Period. That's it. That's all I'm saying. And so
yeah, I
that's it.
That. I agree.
And there we go. Then we're good with that. Now, my other question regarding our partnerships and specifically, I'm really proud of what we've done in the Southeast. I think you highlighted some of the wins. I mean, our numbers actually in the Southeast, which still are our highest incidence of COVID, have gone down. In fact, the incidents now are on par with the rest of the county, and I think we just it has to catch up as far as seeing that. But we are trending downward. So I'm proud of the work that we've done. About 30 events for testing, or 8 more this month. Hired bilingual speakers. So there's all good things we've done. However, I do really think it's critical for us to talk about our relationships. I'm so glad we've hired Harriet Myers and others to work. Harriet actually had a really nice article in the BUMC Reporter this last week. But I did get an email, and I and several board members specifically just asking that it would be appreciated if some of these really critical partners to us have better communication at a more strategic, longer-term level. So from senior leadership, they speak with Harriet and her colleagues regularly and do operationally, but they feel like the response from a higher level is lacking. And I think these relationships with Salome, Conexion, Turk, and others partners, and I'm just naming the ones in the Southeast, are critical, and I just ask that if we can make sure we provide attention to that. That's very critical to me. So those are my two comments.
I really appreciate, and Dr. Jahanger, that and many other inputs and observations you and I have had is the reason why I am moving towards providing my organizational changes, because I am trying to get the department organized in a way to be more responsive. That works for me. So absolutely, that's a great example.
So I agree, and I think I would like to be more specific. I would like to request that, Dr. Caldwell, that you communicate with those particular partners, particularly in the Southeast, because of the urgency, the sense of urgency for that particular population, geographic population in the city.
I missed the word you said.
Well, please let me speak.
I couldn't hear what you said. I couldn't understand what you said.
Can you hear me now?
Yes.
Okay, so for me, it's not enough to say what we're going to do. I need to walk away from this meeting understanding the plan for constant communication from a leadership level on a regular basis. What will that be? And you can send it to us in an email. I know it's not fair to ask you right this minute on the spot, but by tomorrow, we need to know how you're going to communicate with our community partners who have asked repeatedly for information and constant communication. They're not getting that from you. So what is the plan for that to happen, particularly because of the urgency for the populations that they are connected to?
Yeah, well,
it's not a question, it's a request that you share that plan with us tomorrow.
Right. And the plan will be also embodied in my organizational structure also, but I am the one that is directing the communications with all our partners, and so I have only heard good feedback. There's one partner that we're trying to improve that communication with, but all the other ones, we are structured. So once you, I think part of my response is the organizational restructuring, but there's absolutely ways that we can improve, and I know it, and we're going to do it.
Okay, because that is, just to add on, something that has come up every month since the partnerships were formed, and I ask you specifically, individually, and then also in the board meetings, who is really in charge of ensuring that these partnerships are strong and that people are getting what they really bought into. So I don't think that this is particularly new, but this is the first time I've heard you say that you were trying to structure the department such that it would be better for the partnership.
Absolutely. Can you repeat that last sentence?
No, just previously you have said that you were the point person pretty much with the partnerships, and I think that's what we're concerned about, and we're concerned about even when they were formed, that beyond yourself, we've got really talented people who are working in those partnerships, but it doesn't seem like there's any real oversight in terms of the goal and how to strategically meet that goal.
Absolutely. You're absolutely right. And therefore, there's too much decentralization, too many, and the structure I need will address that straight on, and many other things.
All right. Can we talk about the restructuring maybe at another time now? Because I think there's a lot of questions, maybe one-on-ones, and then maybe present in October. Would that be okay?
Well, that's my plan, yes. But I just wanted to say this issue is absolutely directly related to how I need to improve that oversight, because there's too much decentralization. Leadership and supervision will be improved. So that's just one example where there are other areas of the department will also help.
Okay. Thank you. Any other thoughts or questions or further comments, Dr. Caldwell?
I just have a quick question. At the top of his comment, or somewhere in his comments, he mentioned the contract for the epidemiologist ran something. Mm-hmm. We haven't seen that contract, and I don't recall his name. So I'm wondering if you could share the contract with us so we can be familiar with.
Yeah, Mr. Diamond, do you have information on that?
Yes, sir. There's no contract. In the civil service portion of this meeting, we are requesting his hiring above the midpoint of the salary, which requires Board of Health approval, but we don't have a contract to approve with him.
Okay, so Dr. Caldwell, when you mentioned that we had reviewed something, what is the document that you had hoped that we had received and reviewed? Because we have not received it.
No, it's just what Mr. Diamond said, that the board needs to approve his hiring above the midpoint.
Okay, thank you.
Anything else, colleagues? All right, thank you. Hearing none, I'll move on to the report of the chair. Listen, this isn't going to take too much time for the chair. In short, I wanted to say a few things. The charter amendment process that we've been taking on slowly is moving forward still. Tomorrow, I'm having a phone conversation with Councilman Syracuse just to discuss it further. I believe he's now the new chair of that committee. The council chairs just changed. So we'll move that forward. I don't have a date on it, but everything is still as we discussed. I am proud of what we've done as a city in COVID. I think we're heading the right way. I think we've have enough knowledge on that. The vaccine plan Dr. Wright chatted about, it was really important to say we actually, Dr. Caldwell, Dr. Wright, and I met with Commissioner Piercy and her team a week or so ago to talk about how this is going to roll out. There's a lot of ifs in this statement, right? But as I've mentioned previously publicly, most likely the tier 1 will be directly to the health care centers and health institutions for healthcare workers. Tier 2, and by tier I mean like the distribution, the tier 2 will then probably engage this department a lot more, and that will be all the departments that Dr. Wright mentioned and some more, but that's really all we know right now. But I want to make you aware that I was at that meeting. The other thing that I've mentioned privately, and also is as the vaccine trials, if it does pick up, I've mentioned this to Dr. Caldwell, I do have a lot of concern about, he's doing a lot, and I appreciate what you're doing. If he's out late, he's out on weekends, he's doing a lot of work. I do worry about the amount of time the director can commit to providing clinical services. I'm asking for a really clean bookkeeping of that, and make sure it doesn't take away from the other real responsibilities. And we've had that conversation. I'm just making the board aware of that. And then accreditation, I think that's something that was been brought up that we've discussed as well. So that's a very quick thing that my chair's report. I'm happy to field any questions from my colleagues. I know I've just run through a lot of things, but I just wanted to hit the highlights of what I've been up to as chair in the past month. Okay.
I just want to make a kind of process comment. A little bit of tension about between the chair and Dr. Caldwell. Hopefully this will lead us to some clarification of what's expected of the two different roles in terms of the department and the board. The past, in my tenure, one of the concerns about the board role has been that we wanted more active leadership in the department. Unfortunately, it's hard to have that without there being some conflict with the board about being clear about what the boundaries are. And I think we just kind of approached that a bit. I think it's really good that we're going to get to hear Dr. Caldwell's ideas for restructuring, and hopefully it can lead to some resolution of some of the problems, like interfacing with the community that we've had over the past few years. I look forward to hearing them discussed in depth next October. Just wanted to make that observation.
Thank you, Dr. Campbell.
May I respond to Dr. Caldwell? I mean, Dr. Campbell. I think we do have guidelines. I think we have our FAB accreditation process in where it does outline what the board responsibility should be and what the director's responsibility should be. But we also have the guiding document from the National Association of the Local Boards of Health, NALBO. And I'd be happy to share that with those details with Martha, so they'll be at the top of her email to share with the board so we can just be familiar with that, and also share with Dr. Caldwell. Because yes, there are distinct responsibilities, and it's just a matter of all of us level setting to understand where they are. We get so busy in our day-to-day that I think it would be a good time just to sort of pull up and have a refresher of those board roles.
The newest board member very strongly approved.
And we've had in the past, we've had orientations. I had a really, really excellent orientation when I came, and so I was familiar with what our goals were. So yeah,
I would very appreciate it.
We've got.
Thank you. Thank you, Dr. Campbell, for your point. I think it's a very important one. So I hear you. Thank you. Any other thoughts or questions? All right. Review of board requests. Martha, what do you have on your list? If you're still there.
She may be listening from afar, but she's not in this room.
She's not.
And I also have a couple of requests that I want to get on there.
Yeah, as do I.
Yeah.
Okay, Martha, are you available? I need to make sure Martha is available.
She's listening. Hold on. Hold on a second. She's listening. She's listening. She's on. I guess she's not a participant, but she's right there.
All right. So go. I would like to know what she has written down, though, already, if anything.
All right. Let me ask her. I'm sorry.
Oh, here you go. Okay. The reason we're not in our regular board meeting, I think, is.
I have.
Thank you, Dr. Caldwell. Hello, Martha.
Yes. She handed me what she had for this time to review the thank you condolence letter to our staff person. The Board of Health approval of the strategic plan and organization chart, the communications with our partners, and to follow up on this NALBO and FAB accreditation of differentiation between the boards and the organization.
Thank you.
That's what she asked. Okay.
Thank you. And then Carol and Tanae, you guys said you had some other stuff, and any other board members like to add to that list, please?
Yes, I want to reiterate, and I didn't hear the entire list, and this might already be on there, but the plan for communication with our partners, the detailed plan, including how often, with whom, so forth and so on. And we can go back and forth on email if you want any clarity. Also, we haven't heard about the Nashville Strong Babies work in a while regarding infant mortality. And that is a project that also impacts some of our most vulnerable populations. I'm requesting a presentation for next month, if possible. And then lastly, with regards to the vaccine clinical trials and our strategy for recruitment, I remember a phone call last month with Dr. Caldwell and others in which Dr. Caldwell, you specifically spoke to the importance and the desire to make sure the health department recruited African Americans and Latinos to participate. So I want to get tactical and understand what that recruitment plan is from the department's perspective. I just want to make sure that we're doing our due diligence. So that's my request.
Thank you. And Carol?
Yeah, mine are more specific, and I'm happy to do this research unless other board members have the same concerns or interest. We had a really good presentation on opioids and a lot of good statistics here, but I would like to know if and how we interface with the narcotics and the drug enforcement folks, especially on fentanyl. I mean, the statistics are staggeringly bad. And I think that from a public health perspective, we really need to understand more how and what is in the offing to have a better control, if we can get any better control, particularly with the fentanyl. And when we're talking about a potential of 600 deaths this year, and already right now in September, we're 39% ahead of last year. So that is one thing. And as I say, if nobody else is interested in hearing about that, I know everybody's interested, but there's so many things to hear about that I'm happy to just find that out some way or another. And the other thing is MAC, which we always have great presentations. I don't think we need a presentation. I would just like to say how fantastic the save rate is now compared to what it used to be. And for persons who haven't been on the board for a long time, it is exponentially wonderful what has happened in terms of the save rate. We still have 25 shelter euthanasias, and I was just curious at some point to have just a little statement, not a whole presentation, just a statement about what is creating the need for the 25 or whatever number it's going to be.
Okay. Thank you. Any other thoughts, requests?
What the 25, what exactly? 25?
We had a shelter, if I read it correctly, 25 deaths, 25 animals euthanized in our shelter.
Oh, like what? Like you want a list of why? Like
well, I just want to know what the primary reasons are for the euthanized animals. I'm not second guessing that they're necessary. I just want to know what it is.
That's good. Well, we can delineate that. That's a good point.
Okay.
And Dr. Paul, you had mentioned earlier that I had asked for an update on end epidemic, and it just didn't make Martha's list. I just want to make sure that it's on the list. And I'm not saying it needs to rise above any of these other issues. I just like to hear it by the end of the year.
Yeah, you got it. It's on the list.
Thank you.
Thank you. Anything else? All right, that's a long list. Thank you. All right, election of chair and vice chair. Do I hand this over to you, Derek?
Yes,
initially, I was asked to circulate an email that, to my knowledge, each of you received, and I'm prepared to report the interest in these positions that was expressed. Hold on just a second. Sorry.
That's a superb tone. But we're not expecting that one. But please.
All right. So, of course, as the email to you expressed, that I believe Dr. Jahangir, as the chair, is going to open the floor for nominations. But in advance of that, I received emails, and Martha also has been forwarded copies of those emails if anyone ever wishes to check the record. of those that expressed interest in the positions. As to the chair position, there has been only one email that I've received expressing interest in serving, and that is Dr. Jahangir has expressed interest in serving as the chair for this next year. As to the co-chair position, I received 2 emails expressing interest and willingness to serve in that capacity. And those emails, one came from Tanae Franklin, and the other came from David Frederick. And with that, that concludes my report.
And I would, given the nature of where we are with the situation with COVID and also with the reorganization of the department, I wish to remove my name from consideration.
And let me express one thing in case anyone has any confusions. Just because persons expressed interest, it doesn't foreclose nominations from the floor for anyone. So I don't want anyone to be confused by that.
Do you want to count it?
Absolutely. Not at the current moment, no.
And Derek, can I just highlight, these are annual positions, it's 1 year. So the term is 1 year, that's our 1 year term expires at the end of this month or end of this meeting, I guess. So
Can we make a motion?
Yes, ma'am, please make a motion.
I move that Alex Jahangir remain chair and Tanae Franklin remain vice chair for the coming year.
Seconded.
Let me clarify one thing. Nominations are not a motion. It's a nomination, doesn't require a second or a vote. After the nominations are made, that's when the votes will be cast.
Right, I'm sorry.
That's okay. It's an easy process. It's not as formal as the motion process.
There's a nomination that comes on the floor. Yeah, I nominate Dr. Alex Jahangir to continue as the president or the chair of the board.
Second.
If the chair wishes to recognize that nomination, you can request others, or you can close the nomination process.
Well, first of all, thank you both. And of course, I would open up if anyone else has any other nominations, but I would be humble to serve another year. But of course, if anyone other nominations. All right, hearing none, then I would, Derek, do what you got to do for chair, and then I can take over the vice chair part because I'm now chair again.
That would be correct. You would now call the vote. There's no requirement that you recuse yourself from calling the vote. There's no requirement that you not vote.
Thank you. All in favor of making me chair for another year?
Aye.
Thank you. And it is very humbling. I appreciate it. I know this is a hard time. So with that said, I personally would like to nominate Ms. Franklin to serve as vice chair for another year.
Second.
All right. Then Ms. Effington or Dr. Smith, who was that?
Yeah.
The seconds are not necessary.
All right, not necessary. All in favor of any other person interested in no nominations for vice chair? All right, hearing none. All in favor of Ms. Franklin serving as vice chair?
Aye.
Aye.
Any opposed? All right, good. Thank you. And thank you all. We'll try to continue not to serve you.
Congratulations to you both.
Thank you. And
Thank you.
I think you make a good team, and thank you, David. So
Yeah. Very much. Thank you. On that said, I'm going to adjourn this meeting, and I'm going to call in our Civil Service Board meeting. And that's to me hitting the table. So there you go. With that, Mr. Diamond, approval of salary above midpoint for chief epidemiologist, please.
Yes, Dr. Jahangir. The department posted the Health Manager 3 position for the chief epidemiologist, and a candidate, Dr. Rand Carpenter, was selected. He has requested a salary of $110,000, which is above the midpoint for the Health Manager 3 salary. And Section 4.11 of the Civil Service Rules require board approval for any salary above the midpoint.
So can you tell us what the midpoint salary is? And Dr. Caldwell, do you approve of this?
Yes, sir. The midpoint of the Health Manager 3, it's an OR 009 salary grade, is $104,271.35. So it's not very high, very much high over the midpoint, and it's consistent with what the previous person in that position was making.
All right, thank you. And Dr. Caldwell, you're
yes, and just to also clarify, we would not have presented it to you had I not approved it, but yes, I approve it. Thank you.
Thank you for verbally saying that. Okay, any other questions or yes?
I'm sorry if I missed it, but did we get a resume on this gentleman, Dr. Carpenter? Did we get a resume?
May we see it?
Yeah, may we see the resume since we're voting this? Not before the vote, but just in general, if somebody could send the resume.
Yes, we'll have that sent out to you. I would like to just give a brief synopsis of his resume. He's a veterinarian. He was an EIS officer stationed at the State of Tennessee Health Department. He then stayed for 7 years in a deputy epidemiology position in the same position that Mary Margaret Phil has now that you probably know her, reporting to Dr. John Dunn. So Dr. Rand Carpenter worked closely with John Dunn as well as Tim Jones, comes highly recommended by both of them, as well worked very closely with Mr. Hugh Atkins because Mr. Atkins had been previously the Director of Environmental Health at the State Department of Health and worked closely with him. So all received very high recommendations. He has subsequently, when he left the State of Tennessee Health Department, has been working in a series of international nonprofits and is really looking forward to joining our team as a seasoned epidemiologist leader, as well as with the educational background of a veterinarian. We're really grateful for his interest in joining our team.
Thank you.
Well, I would motion to approve this salary request.
Second.
Okay, any further discussion? Okay, hearing none, all in favor? Any opposed or abstentions? Dr. Smith, I'm assuming you're aye. I don't see you.
Yeah, aye.
Thank you. Perfect, thank you. And then personnel changes.
Yes, included in the packet were the August 2020 personnel changes. Sadly, for the second time in less than a year, we lost an employee who passed away. But if there's any other questions, I'd be happy to entertain them.
Thank you.
How long had Dr. Nagol been with us as an epidemiologist?
It was about 2 years. He was a CFP.
Okay.
Any other questions or thoughts?
Thank you.
All right. Hearing none, I'm going to adjourn this meeting as well. So thank you all so much for everything, and it's always good to have this meeting. So grateful to all of you. Have a good day.
Thank you.
Thank you.
And here you are, Calvin.
Thanks for the show.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information about this and other programs, visit nashville.org.